The epithelia can be many types and we want to talk about them. It could be a single layer, then it'll say simple epithelium, and it can be multiple layer, then you can say stratified. So multiple layers is stratified. Is it always stratified? Not necessarily. It could be pseudo-stratified. It could be transitional. Let us start with simple epithelium first, single layer on the basement membrane. You see, if it is a flat cell with flat nucleus, then you say simple squamous. If it is height equal to breadth and a central spherical nucleus, then it is cuboidal epithelium. Height is equal to breadth and central spherical nucleus, cuboidal epithelium. And if height is more than the breadth, oval basal nucleus, then it is simple columnar epithelium. We have to draw them ourselves. But before that, you see a question. Thyroid follicles are lined by. What do you think is your answer? I have triple answer. Now, if you got triple answer, then which is the best one? Then I'll take this one. Why would you take this one? Why simple cuboidal? Because when I look at the thyroid follicles, I see they are lined by some cells having central spherical nucleus, and height of the cell is equal to the breadth of the cell. This is thyroid follicle lined by follicular cells which have central spherical nucleus, cuboidal epithelium. Is it always cuboidal epithelium? It depends how much of thyroxine you are secreting. If you have a scanty thyroid, squamous. If you have medium level, then cuboidal. And what if it is a high level of thyroxine secretor? They become columnar. In fact, if somebody asking you secreting active thyroid follicle, you have to change your answer now, because when it is secreting active thyroid follicle, they'll have a lot of endoplasmic reticulum, increasing the height of the cell, becoming columnar. So you mean to say a lot of thyroxine is being secreted now? Yes, it has become simple columnar. Let us discuss this again. See, this is the basement membrane, and on the basement membrane, I have a flat cell with flat nucleus. If you say this is a flat cell with flat nucleus, then what do you call it as? What I call it as is a simple squamous epithelium. So is it always flat nucleus? No, not necessary. It can be globular also, but usually it is flat. Flat cell with flat nucleus is simple squamous. How do you identify the simple cuboidal? Simple cuboidal, I'll have height equal to breadth. Height of the cell is equal to breadth of the cell, and there is a central spherical nucleus. Central spherical nucleus. Now, if you say it is a central spherical nucleus, then what kind of epithelium is this? This is simple cuboidal epithelium. Now, if you say this is a simple cuboidal epithelium, what about the simple columnar? That we'll see. This is height more than the breadth now. So you're telling that height is more than the breadth. What else? There is a oval basal nucleus. Oval basal nucleus. So now you got the height is more than breadth of the cell. Yes, breadth is less. And there's oval basal nucleus. Yeah. Why? Because I had lot of endoplasmic reticulum. And why you were having lot of endoplasmic reticulum? To give the thyroxine hormone. You mean to say actively secreting thyroid follicle? Yes, actively secreting thyroid follicle, more of endoplasmic reticulum. To keep that endoplasmic reticulum, I am increasing the height of the cell. So this is what we call as the simple columnar epithelium. Now, if you say this is the simple columnar epithelium, it is in the actively secreting thyroid follicle. Yes. What if I simply say thyroid follicle? Then it is simple cuboidal. And what if I say resting follicle? If it is resting follicle, then your answer will become simple squamous. So, resting thyroid follicle, simple squamous, less of secretion. And simple cuboidal, normal thyroid follicle. And secretive, actively secreting thyroid follicle, simple columnar. That is the way you will tell the answer. Now, if you are talking about simple squamous epithelium, it is flat cell with flat nucleus, but not necessarily. It could be globular also. So simple squamous epithelium with flat cell with flat nucleus may become globular also. Where did you see that? Resting thyroid follicle. Where else did you see that? Mesothelium. What is mesothelium? We have already told peritoneum, pleura, pericardium. So you mean to say peritoneal serosa? Yes, peritoneal serosa. And it could be the pleura, it could be the pericardium also, having mesothelium, which is simple squamous epithelium. And what about the simple cuboidal epithelium? If it's a simple cuboidal epithelium, we'll say central spherical nucleus, height is equal to the breadth of the cell. Height is equal to breadth of the cell, central spherical nucleus. This is cuboidal epithelium. This is the basement membrane. Where did you see that? In the thyroid follicle. What other place you see that? Simple cuboidal epithelium. Yeah. See, in the kidney, PCT, DCT. So in the kidney, PCT, DCT, you mean to say proximal convoluted tubule, distal convoluted tubule is simple cuboidal epithelium? Yes, they are. Height is equal to breadth, central spherical nucleus. PCT, DCT is also the simple cuboidal epithelium. What about simple columnar? Oval basal nucleus, and height is more than the breadth. So you are telling that there is a oval basal nucleus, and height is more than the breadth. How do you know height is more? Because more of cytoplasm above the nucleus. More of cytoplasm above the nucleus. This is a feature of columnar epithelium. And where did you see the columnar? Actively secreting thyroid follicle. Where else? Intestine and stomach and other places also. So stomach, intestine. What kind of epithelium is there in small intestine? Actually, they were microvilli to increase the surface area of absorption, and they are regularly arranged. And because they are regularly arranged, they are called as striated border. So striated border is there in the small intestine. Yes, regularly arranged microvilli in the small intestine gives striated border to increase the surface area of absorption. Yes. Okay, fine. What about the stratified then? Stratified epithelium means multi-layered. So multi-layered, fine, but where do you find that? Any place where I need protection from aberrations. See, stratified squamous epithelia are usually present in surfaces where I need protection from the surface aberrations. It could be non-keratinized, it could be keratinized. On the other hand, we have to consider transitional in the renal tube, urothelium, and pseudo-stratified ciliated columnar with the goblet cell in the respiratory tube. So this is under stratified epithelium, though they are not pure. See, I told you, pseudo-stratified is not exactly stratified, and transitional is not exactly stratified because each cell is touching the basement membrane. They cannot qualify as stratified as such. They are different. So what about stratified then? Stratified epithelium I see at places where I need protection from aberration. Could be oral cavity. Is it keratinized or not was a question. We have to see. But it is stratified squamous epithelium. How do you know it is stratified squamous? Because the superficial cells are squamous. Superficial cells are squamous. What about the basal cells? They are columnar. So basal cells are columnar, middle layers are cuboidal, only superficial layers are squamous. The superficial layers decide the name. Squamous stratified epithelium. Found where? At the openings, various openings in the body. Like what openings? Oral cavity, nasal cavity, eyes, ear, and also opening in the perineum. That could be urethra, vagina, anal canal. So various opening in the body like oral opening, nasal opening, eye opening, ear opening, or maybe perineum, you have urethra, vagina and anal canal opening. All are lined by stratified squamous epithelium. We'll have a rule to follow actually. And what about the answer here? Lingual surface epiglottis. If you say lingual surface, it is oral surface in the oral cavity. Whatever oral cavity lined by, the answer. You mean to say oral cavity lined by stratified Squamous epithelium, that is the answer? Yes. Okay, but then epiglottis is having double surface. It has the oral surface, it has a laryngeal surface. What about the laryngeal surface? If you say the other surface, laryngeal surface, then it will be respiratory epithelium, pseudo-stratified ciliated columnar epithelium. If somebody asks you laryngeal surface of epiglottis, this is the answer. But this question was on lingual surface. So you have to keep your answer as stratified squamous epithelium. D is the answer here. Now, if you are talking about pseudo-stratified ciliated columnar epithelium in the respiratory tube like the laryngeal surface of epiglottis, there will be some cilia also to move the mucus. Yeah, respiratory tube requires cilia to move the mucus. And why do you say it is pseudo-stratified? It is pseudo-stratified because each cell is touching the basement membrane. It cannot be called as stratified. See, we will have to discuss this epithelium in great detail, not yet. It is just an overview. So later we'll see some details. At this moment, you are talking about transitional epithelium as well. What about transitional epithelium? Where do I find it? Urinary tract, urothelium. Let us look at the urothelium, taking a specimen from the urinary bladder. And as you magnify, you will see this is the epithelium. Let us still magnify it, the urothelium. As you magnify it, you will find that the cells towards the lumen are quite large cells. Cells towards the lumen are quite large cells, and they are called umbrella cells. They have a shape of umbrella. Like the shape of umbrella, they are appearing. So, you mean to say these cells towards the lumen are umbrella shaped cells? Yeah, very large cells towards the lumen and umbrella shape. If you are storing the urine, then the epithelium will be stretched. And if you are, if there is no urine in the urinary bladder, then you will see they are relaxed. So, sometime it will appear too many layers, 5-6 cell layer, and sometime it will appear only 2-3 layers. So, when it is stretched, it is 2-3 layer. When it is relaxed, then it could be 5-7 layers. So, it is stretchable epithelium, transitional epithelium. One more thing, as I told you, each cell attaches to basement membrane by some cytoplasmic extension. So, they cannot actually qualify as the stratified epithelium. This is called transitional epithelium. And you can be confused between the three. Sometimes they'll give you pseudo-stratified epithelium. How do you identify? If it is stratified squamous, how do you identify? And if it is transitional, how do you identify? Transitional means the cells towards the lumen are umbrella shaped. They are globular, but that is not the scene in the stratified squamous. They are flat cells. So, flat cell towards the surface is stratified squamous, and globular cells towards the surface is transitional epithelium. And what if it is pseudo-stratification with cilia? Then it is respiratory epithelium, pseudo-stratified epithelium. Just to have some idea of differentiation between the three types. Sometimes it can be confusing. We'll keep discussing the differences again. At this moment, I want you to learn one rule for stratified squamous epithelium. The rule simply says, any external opening in our body is always lined by stratified squamous epithelium. We'll make a diagram for that purpose now. So, you are telling about the rule. What is the rule? Rule is any external opening in our body is always lined by the stratified squamous epithelium. There is a rule in embryology also. Do you remember? The embryology people says any external opening is lined by surface ectoderm. That is embryology rule. So it is understood that wherever we have surface ectoderm, we'll have the stratified squamous epithelium. It's understood. So any external opening is lined by surface ectoderm is lined by stratified squamous epithelium. But be careful. The stratified squamous epithelium is not only present on surface ectoderm, it can be present on the endoderm, and it can be present on the mesoderm also. Now, if you say it is present on the mesoderm, endoderm also, can you give some example? Yeah, like vagina. What is vagina developing from? Upper vagina from mesoderm and lower from endoderm. Now, when you say upper vagina developed from mesoderm, lower vagina developed from the endoderm, but entire vaginal epithelium is stratified squamous epithelium. So, my point is simple. Stratified squamous epithelium is present not only on ectoderm, but it can also be seen on the mesoderm and the endoderm. Now, generally, we find stratified squamous epithelium is on the external opening, but not necessarily. Rarely, it may be seen on the internal opening also. Now, if you say rarely, it can be seen on the internal opening. Example, can you give some example? Yes, like vocal cords. Now, if you say vocal cords, is it internal opening or external opening? It is internal opening. So, internal opening can be lined by stratified squamous epithelium. Why it is lined by stratified squamous epithelium? Because normally we need stratified squamous epithelium for protection against abrasion. So, do you think there are some abrasions occurring at the vocal cords? Yeah, it happens. How? You see, this is the larynx and there you have the vocal cords. So vocal cords are prone to abrasion. How come? Because whenever we are coughing and sneezing, there is a fast moving air. When we cough, when we sneeze, there is fast moving air. So while coughing and sneezing, there is a fast moving air. It can cause abrasion of the vocal cord. Abrasion of the vocal cord can be prevented by putting some epithelium which is stratified squamous epithelium. Hence, the vocal cord are lined by stratified squamous epithelium. Otherwise, what is larynx lined by? Otherwise, what is larynx lined by? Of course, the larynx should be lined by respiratory epithelium. And what is respiratory epithelium? It is pseudo-stratified, ciliated columnar epithelium. We already know that. So, you mean to say pseudo-stratified, ciliated columnar epithelium is missing from the vocal cords? Yeah. Vocal cords do not have respiratory epithelium. They have stratified squamous epithelium, which is protecting against the abrasion. This you remember. So, what about that rule you were telling? Some stratified squamous epithelium lining opening. There are 7 openings you have to remember. 4 on the face and 3 on the perineum. What are the 4 openings on the face? The oral cavity, nasal cavity, eyes and the ear. And what are the 3 openings in the perineum? You know that. Urethra, vagina and anal canal. So first we talk about the face. As you're drawing the diagram, this is opening number 1, 2, 3, 4 on the face, lined by stratified squamous epithelium. Why? Because this area is prone to abrasion. That is why. What is prone to abrasion? The opening of the eyes and ear and nose and oral cavity. Let us draw that in the diagram also. Then you are telling that this is the face, the eyes and nose and ear and the oral cavity. What kind of ear is this? Actually, what I want you to understand is this is the middle ear cavity and that is the external ear canal. So, if you tell that this is the ear and it is the external ear canal, this is the middle ear cavity, what is it separated by? The tympanic membrane. This is the tympanic membrane. I want to talk about the epithelium on the tympanic membrane actually. Because tympanic membrane has double epithelium. The inner epithelium is different from the outer epithelium. It has double epithelium and outer inner epithelium is different. This is what we want to discuss. Okay, then tell about the eyes. Eyes have cornea. The first layer of cornea is lined by. Eyes have cornea and the first layer of cornea is lined by the stratified squamous epithelium because it is prone to abrasion. So, in the eye, the first layer of cornea, the surface epithelium of cornea is stratified squamous epithelium protective against abrasion. What about the ear? If you are talking about the ear, then external ear canal and outer surface of tympanic membrane. If you're talking about the ear, then external ear canal and outer surface of tympanic membrane. What is it lined by? It is lined by stratified squamous epithelium, but only the outer surface of tympanic membrane here. What about the inner layer then? If you are talking about the inner layer, then it will be same as the middle ear cavity. What is middle ear cavity then lined by? See, tympanic membrane will have double epithelium. If it is outer surface of tympanic membrane, then it will be same as external ear canal, which is stratified squamous epithelium, but not the inner surface of tympanic membrane. It will have the same epithelium as the middle ear cavity. What is middle ear cavity lined by then? Near the tympanic membrane, the middle ear cavity is lined by stratified cuboidal epithelium. So, as the middle ear cavity is lined by stratified cuboidal epithelium will line inner surface of tympanic membrane. What about the opening of the nose, which is called as the nasal vestibule? If you are talking about the nose or the opening nasal vestibule, it is lined by skin with hair. If you say it is skin with hair, then I know what the epithelium will be. The opening of the nose nasal vestibule is lined by skin with hair, and that will be, of course, stratified squamous epithelium. What about the oral cavity? When you talk about the oral cavity I will discuss in two parts. I will tell you about the tongue and the hard palate separately, and what about the others, content of the oral cavity. Then I'll talk about the, say we are talking about the tonsil and epiglottis. Which part of epiglottis? The lingual surface, oral surface. Okay. So what about that? See, oral cavity, whatever inside that is all lined by stratified squamous, but there's a difference. You mean to say all the four are lined by stratified squamous epithelium? Yes, but there's a difference. What difference is there? Actually, you have to understand that tongue and hard palate are keratinized. Keratinized like skin. No, not like skin, but they are keratinized, which is called as orthokeratinization and parakeratinization. Now, if you say tongue and the hard palate are keratinized, which is not like skin, and they are orthokeratinized and parakeratinized. How do I differentiate between this keratinization and the keratinization which is on the skin? We'll find a diagram and discuss for that. But it is not the same keratinization as the skin. Okay, then what about the tonsil and the lingual surface of epiglottis? Non-keratinized. This is non-keratinized. So this is non-keratinized. Yes, it does not have keratin. You mean to say tonsil and epiglottis are non-keratinized, stratified squamous epithelium? Yeah, that's the point. That is the point. And how do you differentiate hard palate from the skin epithelium? Hard palate epithelium, skin epithelium. That is, we will discuss. But here, I'll just want to tell you, the ear and nose are lined by skin. And because ear and nose are lined by skin, they'll have some glands, sweat gland and sebaceous gland. There is a description of a sweat gland in the ear. It is called ceruminous gland. Can you tell me, ceruminous gland in the ear is a sweat gland. Which type of sweat gland is that? See, my point is, ear and nose are lined by skin. They'll have glands like sweat gland, sebaceous gland. And ear has a ceruminous gland. Which kind of sweat gland is that? Understand, ceruminous gland or the wax gland in the ear is a modified apocrine sweat gland. It is apocrine sweat gland. This comes as a question. So, ceruminous gland in the ear, which is wax gland, is apocrine sweat gland. We'll see some details of that shortly. At this moment, I just want you to understand what is the difference between parakeratinization and the actual keratinization. The actual keratinization you can find on the skin, and parakeratinization you can find on the hard palate, or maybe you can see that on the tongue also in the oral cavity. So in the oral cavity, hard palate tongue has parakeratinization, but in the skin you have keratinization. What is the difference? See the difference. Simple. It is the superficial cells of a keratinized epithelium have no nuclei. No nuclei in the superficial layers, but there are nuclei in the superficial layers if it is parakeratinized. So parakeratinized is identified by the fact that superficial cells have nuclei, which is missing in the actual keratinization. This is the difference between the two things. About the skin epithelium, we'll see some more details, but later, not here. So what is now the 7 openings you were talking about? 4 on the face and 3 in the perineum. The 3 in the perineum. What about the perineum? As we're talking about the perineum, we will see that a female perineum has 3 openings. In lithotomy position, you have put a female in lithotomy position. You are looking at the perineum and talking about urethra, vagina and anal canal. Let's draw the diagram and discuss the epithelium. So this will be opening number 5, 6, 7. Yes, opening number 5, 6, 7, because we have to discuss 7 openings lined by stratified squamous epithelium. And what are they? Now it is most anterior urethra, followed by vagina in the middle, and most posterior is anal canal. That you can draw in the female perineum like this. So what is most anterior? That is the urethra. And what is middle? That is vagina. And what is most posterior? Anal canal. Now understand, urethra, especially female urethra, which is only 4 centimeter in length, is almost entirely lined by stratified squamous epithelium. Since the female urethra is quite short length, 4 centimeter only, almost entirely it is lined by stratified squamous epithelium. But this will not be happening in male urethra. In male urethra, which is actually 20 centimeter long, only the tip of male urethra will be lined by this epithelium, not the entire urethra. So for a male, since it is a long urethra, 20 centimeter, only tip of the male urethra will be lined by stratified squamous. Otherwise, male urethra has different epithelium. And what is that? That we'll find out by drawing a diagram. But at this moment, just remember, if it is opening, then it is stratified squamous. What about the vagina? We already know entire vaginal epithelium. Entire vaginal epithelium is stratified squamous epithelium. What about the anal canal? Anal canal below the pectinate line, below the dentate line. Pectinate is also called as dentate line. So maybe say pectinate or dentate, whatever. Below the dentate line or pectinate line, you have the stratified squamous epithelium. But what is above that? What is above that? If anal canal below the dentate or pectinate line is stratified squamous epithelium, what is above that? That we'll find out. What is above that later. But the openings are stratified squamous epithelium. Now, once you have all that details with you, you are supposed to look at some squamocolumnar junctions, because they're prone to metaplasia, prone to dysplasia, prone to cancers. You must be careful about these areas. Wherever you have squamocolumnar junctions, there is a chance of metaplasia and leading to dysplasia, leading to cancers. Like which places you can talk about? Anal canal, cancer, anal canal, cancer of esophagus, cancer of cervix. So we have to talk about these 3 now. But here, I'll focus upon esophagus, because there are questions on esophagus. Then we will talk about anal canal also and cervix also. At this moment, I want to talk about Barrett's esophagus. A very hot topic, not only asked in anatomy, but also pathology and surgery and medicine. So I'll talk about all the 4 questions. What about Barrett's esophagus? How will you diagnose Barrett's esophagus is a question. What do you think is the answer? It's a controversial question, actually. Anyway, what is the answer? If you read Harrison Medicine, it will say it is intestinal metaplasia. And what if you read Bailey Love surgery? It is intestinal metaplasia. And what if it is Pathology Robbins? It is intestinal metaplasia. You mean to say all the 3 books telling intestinal metaplasia? Yeah. Harrison Medicine, maybe the Bailey Love surgery, maybe the Pathology Robbins, but not the Gray's Anatomy. Gray's Anatomy is telling gastric metaplasia. Why Gray's Anatomy telling gastric metaplasia? Explain. And also tell what could be the answer, because now you have double answer, you see. Will you follow Gray's Anatomy or not? This becomes quite controversial. I'll prefer D is better than C. Why D is better than C? Because you have to choose one thing. Either you follow Gray's Anatomy or you follow 3 other books. It is kind of a democracy now. Vote. Who's getting more votes? 3 votes. Who's getting less votes? 1 vote. So, you see, you got a case of GERD. What is that? Gastroesophageal reflux disease. The acid is coming from the stomach and coming to lower esophagus and changing the epithelium. Normal epithelium is squamous, but it is being replaced by the columnar epithelium, which is dangerous because there is a metaplasia. And when there is a metaplasia, it is prone to dysplasia and cancer. Which cancer are you talking about? Adeno cancer, lower esophagus, adenocarcinoma. You have to prevent that. You must treat your patient properly, otherwise a case of GERD might result in metaplasia, dysplasia and cancer. What metaplasia is that? It is Barrett's esophagus you are talking about. Now, if you are talking about Barrett's esophagus, I want to make a diagram for that. And let's do that. But you see, normally there is a squamo-columnar junction in the esophagus which is called Z-line. What is Z-line? It is a zigzag line. And where do you see the zigzag line? At the lower end of the esophagus. It is squamo-columnar junction. Now if you say this is a squamo-columnar junction, you have to understand lower 2 centimeter of the esophagus is lined by columnar epithelium, just like the stomach. So lower 2 centimeter of esophagus is lined by columnar epithelium, just like the stomach. What is the rest of the esophagus lined by? See, this whitish mucosa is stratified squamous epithelium and this pinkish is columnar, so there is a Z line or squamo-columnar junction. You have to remember that. Now, histologically, if you look at the epithelium, again you will find the same thing. The upper esophagus, the whitish mucosa is stratified squamous epithelium and the lower pinkish mucosa is columnar epithelium, and you are having a junction which is called as squamo-columnar junction, and this junction is prone to metaplasia or dysplasia or cancer. This is important. It can happen in cervix also, uterine cervix. It can happen in anal canal, cancer anal canal, because they have these junctions. But this is esophagus we are talking about. You see, in the esophagus, at the lower end of esophagus, we are having this Z line. Normally, it is 2 centimeter above the gastroesophageal junction, which is here. So 2 centimeter above the gastroesophageal junction, but in this patient it became 5 centimeter above the gastroesophageal junction, means it is going more proximal, and when it goes more proximal there is a danger that this area will develop cancer. You should make sure that this line should not ascend up. It will be dangerous for the patient. This is the gut tube. Which part of gut tube you are looking at? This is the oral cavity. If you say this is the oral cavity, then it will continue as the pharynx, will continue as the esophagus. So, gut tube, this is the oral cavity which will continue as the pharynx, will continue as the esophagus, will continue as esophagus, will continue as the stomach, and stomach will continue as the small intestine. Which part of small intestine is this? This is the duodenum. Now if you say this is the small intestine duodenum, then this must be the stomach. Yes, that is the stomach. You are talking about the gut tube here. So oral cavity, the food will enter, go to pharynx, then the food will enter the esophagus to enter the stomach and the small intestine, which is duodenum. This is proximal duodenum. Now if you say this is proximal duodenum, this is distal esophagus, that is distal esophagus. You can mark here what is called as the gastroesophageal junction, GEJ. What is GEJ? You write here GEJ is the gastroesophageal junction. But then there is also the SCJ. What is SCJ? That is squamo-columnar junction. And what about the SCJ then? See, what we have shown is gastroesophageal junction. GEJ is gastroesophageal junction, but there is a squamo-columnar junction also. Where is SCJ? You have known that 2 centimeter above that will be the Z line or zigzag line, and that is the SCJ. So 2 centimeter above the gastroesophageal junction. You have the Z line, zigzag line, that is the squamo-columnar junction. And what are the other details? If you remember, we have discussed what is oral cavity epithelium. It is stratified squamous epithelium, and this oral cavity epithelium, which is stratified squamous epithelium, is not only there in the oral cavity, it is encroaching into pharynx, it is encroaching into esophagus also, but not entirely. So stratified squamous epithelium will be in the oral cavity, pharynx, and reaching till the lower esophagus, but not the lowermost, because lowermost is different. How is it different? You know what is stomach and duodenum lined by? Stomach and duodenum are lined by the columnar epithelium. Yeah, so this columnar epithelium, which is lining maybe the stomach and the small intestine, is also lining the lower 2 centimeter of the esophagus. So you mean to say the small intestine or the stomach, which is lined by columnar epithelium, is also lining the lower 2 centimeter of the esophagus. That is why there is a squamo-columnar junction at the Z line, which is 2 centimeter above the gastroesophageal junction. Yeah, that's the point. But then there can be problems if it is a case of GERD. This was a case of gastroesophageal reflux disease. Some acid was coming, and that acid was entering the esophagus, lower esophagus. So it is a case of GERD, gastroesophageal reflux disease. Some acid is entering the esophagus, lower esophagus, and what happens is this acid is burning the epithelium, replaced by columnar epithelium, and it called as metaplasia. In Barrett's metaplasia, when you take the biopsy, what you find is the squamous epithelium is replaced by columnar, and in a biopsy you also found goblet cells. And since in your biopsy you found that it is columnar epithelium with goblet cells, you were calling it as intestinal metaplasia. Why will you call Barrett's metaplasia as intestinal metaplasia? Because in the intestine I find the same epithelium, columnar with goblet cell. That is why I am telling that Barrett metaplasia is intestinal metaplasia, but it is a misnomer as written by Pathology Robbins. Pathology Robbins says calling Barrett metaplasia as intestinal metaplasia is a misnomer. Why? Because this columnar epithelium is not for absorption. It is not doing absorption, and because columnar epithelium is not doing absorption, how can you call it as intestinal metaplasia? It's wrong. Now maybe it is wrong, but Harrison calls it as intestinal metaplasia. Surgery, Bailey Love calls it as intestinal metaplasia. Pathology itself calls it as, Robbins calls it as intestinal metaplasia. So I will also call intestinal metaplasia, despite the fact that Gray's Anatomy was calling it as. If you are looking at Gray's Anatomy, then it will say it is gastric metaplasia, and they have their own reason. What is their reason? Actually, they found something here called parietal cell. So you mean to say that some biopsy was taken? Yes. And in that biopsy there was some parietal cell found? Yes. That's why it is also called gastric metaplasia? Right. But then it is also a misnomer. Calling the Barrett metaplasia as gastric metaplasia is a misnomer. Why? Because do you think that stomach has goblet cells? No. There is no goblet cell in the stomach. Stomach don't have any goblet cell, but there I found goblet cell. So how can you call it as gastric metaplasia? So in fact, it is also a misnomer. Maybe you found parietal cell here, but you also found goblet cell. Do you have goblet cell in the stomach? No. So then it remains a misnomer. But I'll prefer that somebody asking me Barrett's metaplasia, the best answer should be intestinal metaplasia. If not found, you can also call it as gastric metaplasia. Now you must be wondering, you are focusing upon one single diagram for such a long time, but you don't know. In a single diagram which we draw, there are some 7 to 8 MCQs already taken care of. That is how I teach. I teach in such a way that I'll draw a diagram, discuss one question, but in the end you will realize, when you practice MCQs, you will realize that you have already taken care of 6 or 7 MCQs. It happens automatically. That is my way of teaching.